The final speaker is here. The other piece of good news is I'm timing myself, so I will hold to my timing. I'm a marketer, and so you think marketers are those people that are like win every argument. No, actually, marketers are the people that change the argument so they win in the end. That's really, so we're sort of lazy people that are looking for the easiest way to do something. Let me see, I push the green to move this. That? Yeah, let me figure out how to, the green button, right? Green button. There you go, okay. Didn't press it hard enough. So remember that. I'm looking for the easy way to get something done. So this is sort of the assignment. We're working with Compassion and Choices on empowering patients at the end of life and kind of end of life broadly. So there's a lot of things we lose in old age, and we didn't want to lose control of our health care. I'd say, okay, that should be simple. We'll just add some empowerment here and get some behavior change with the doctor, and it should be no problem. Of course, completely wrong. Because one of the first things we decided, so this is a bunch of the research we did, and you can read that as well as I can do. We did a rapid research review, which is basically like a lit search, but really fast, and then key informant interviews. We did 80 in-depth interviews with caregivers and family members. At one point, we tried to divide it up between people that had good deaths and bad deaths. Don't ever tell somebody, like, don't you want a good death? That is not something to say, because as we've been talking about, it's about living. We talked to very seriously ill patients. We talked to oncologists, gerontologists, cardiologists, palliative care. We were able to identify, and I'm not going to say which, certain specialties were so much friendlier than others, and then clergy members and social workers. And then we did, and this is just the initial research, we added some questions to a survey of about 3,500 people. And so we thought, our assumption is, we could engage at the time of the terminal diagnosis. And this is just two of many, many findings. What we found out is there's often no clear recognition of the terminal until the end. So that's, I think you said, it's never too, it's always too soon until it's too late. And we thought we could give people the power they want. Here we can empower you and you can take control of your doctor. And they're like, no, I'm not worried about that. Everything's going to work out well. I'll just go and, that's how it works. They just tell me what to do and then everything works out well. And we know that's not the case. So this is, and this is formative research. A lot of what we've been talking about before, people that have done things and then tested them, this is formative research where you're basically learning about how stupid you are as the day goes on with different research. And we kind of came up with this pattern of this is sort of how things are going. People are moving from independence to dependence, essentially. And where is our opening? And all these were different tools. We were looking for, products we could design that might make a difference. And there's a lot of work being done on the independent stage. I think Ellen's work is part of it, of helping people prepare, helping people get different, get things in place, although we know ADs have a lot of challenges. For me, from a product design guy, it seems to be like not exactly the perfect tool for the job. And then there's also the dependent stage, but you really need the key stage turned out to be the benefit during burden moment. And that's really where the rubber hits the road, where you're making some decisions about your care. And, people were looking to help understand the doctor, help my doctor understand me, and help my family support me. So you could begin to see the laziness here, because what I'm looking for is what people already want. Instead of trying to convince them about you really should get this, I'm going to give them something they already want, and then when everybody buys it, people will think I'm brilliant. So there's lots of work here. I think I just went through this. That's not the really sole intervention point, so let's focus here. This is where the real change takes place. And another thing that came up in this as we thought through this is, what are patients really seeking? And this is from the qualitative work. And at the benefit and burden stage, people say sort of like this, the first level is sort of what they say, okay? And the second level is sort of the emotional benefits that it goes to. And the top level, those are the values. That's the ultimate thing. And, being a loving mother, father. So part of that is to be more concerned about not burdening your children, for example, than you are about doing what you want to do. But you still have by being true to yourself, living life to your fullest. Good death, not there. So how could we help there? So then we did yet more research. One of the project managers on this was on the client side was a research guy. You can probably tell. So we had 29 dyads testing some product concepts with seriously ill people and caregivers dyads. So there's two. There's the seriously ill patient and the caregiver together. And we did a national survey of 1,500 adults. And then we did, and those are all over 50. Then we did 21 focus groups. We did a sprint, a prototype testing, and we then tested a bunch of names and tags. And so our assumption going into this is we can make some great tools, and people don't want end-of-life tools. No one is at the end of life until they're really, really at the end of life. People want better life tools. Okay. And but there is this issue of that while people think I got to say near the mic, their doctors are awesome and they have total trust in their doctors, they do have a feeling that they aren't being necessarily as candid as they could be. And they want people to be more candid. So this could be, it could be an opening. Oh, I'm pressing the wrong button. That's my problem. So this is sort of our oversimplified approach that we thought at first. We thought we're going to create a market forces that are going to help change. There's been a lot of work, and there still is a lot of work, and a lot of good work being done from inside the system, changing what doctors are doing. We wanted to work with consumers and create market forces that would change. And we thought we'd have them demand something, and the doctors would give it. But they're really not in the demanding mood. And they're not really ready to, have this big campaign, and then it's not like they're going to say, oh, geez, yeah, you're right, we're going to do things totally differently. Because, and the doctors, of course, aren't the only people in the medical system, as the doctors here know. And so I think what we came down with was the real disruption are the questions that people ask, and that's the trigger. And by the questions they ask and the relationship they build, this relationship, that's really important. And it's not just a conversation, it's a relationship. We talk about conversations as a way to build a relationship, but it's sort of like, so years ago we worked with Planned Parenthood on the talking to your kids about sex. And it isn't a conversation. It isn't a single conversation. What we found is the people with the best relations are people that you could constantly bring it up in different ways. By the way, I'm still waiting for my conversation about sex from my mom. I have 4 kids, and I'm still we came up with a couple different products I'm going to explain to you. One is this idea of a trust card, and you do it online, and it's really kind of a double intervention in a way, because just filling it out, so it asks you 3 questions, and by your answers to those 3 questions, it kind of writes a note to your doctor. And if you're my parents' age, who are in their 80s, then you're seeing doctors. You got your healthcare schedule is sort of like my work schedule. It's pretty full, and they're different doctors. So how do you get them to know you, and how do you get them to have your back and have them feel that way, and let them know, like the great the hello game that gets you, or the intervention that you had in that hospital that gave, how do you get them to think of you and treat you and see you as a person? And this kind of goes to the same place, only it's just an online tool. I could go on and on about it, but I won't. The other piece is the diagnosis decoder, because this is, again, remember, I'm changing the argument so I win in the end. And so rather than tell people, we really want you to talk about death. And we were really working hard there. And we kept striking out, and we think of another way, and then eventually we did so much research, we had to listen to the data at some point. And so, but what people want is, they want to figure, how do I figure out what's my role in this? And to have a completely passive role, if you can get people to take a little bit more active role, because they want to figure it out. They want to have we called this at one point the doctor decoder. Like, what's going on here? What am I supposed to do? What are my questions I had to ask? But as you go through figuring out what questions to ask, you're being changed in how you're looking at things, and then the questions you ask are bringing up other alternatives. So you're a more empowered patient but accidentally. We aren't telling you, you need to be empowered and come here to be empowered, because people aren't shopping really for empowerment. They really want to do this because they think their doctor will like them more. And that's one thing that people want. They want their doctors to like them. So, so anyways, that's it. I think I came in well in with my time.